Good afternoon. Welcome everybody to this session this afternoon on research. I'm delighted to see that at least two of our speakers are with us at the moment. And I think it's going to be a really interesting panel session. I'll introduce myself. My name is Corinna Alberg. I work as part of the Cambridge Africa team as a programme coordinator with two African-based health research capacity development programmes called Thrive and MUII. And one of our speakers, Arthur Kwizera, is a MUII fellow, sorry, a Thrive fellow. I was also really pleased to hear about Evelyn talking about Harambee, because it brings me back to my first contacts with Africa when I taught in a Harambee school in Kenya. So it's always sort of very pleasant memories that are brought back to that important phrase of everybody pulling together. I'm delighted to be chairing this afternoon's panel session on research. We are going to have three very interesting presentations to look forward to that will provide a diverse picture of research-related activity between African research partners and Cambridge and the east of England. Our format will be that each presenter will present for 10 minutes and then we'll have time for one or two questions after each presentation. If you could type questions in the chat box, I'll ask you to unmute yourself and pose the question to the presenter. Unfortunately, we probably won't have more than time for about one or two questions per presenter. And as Evelyn mentioned, a link will be put in the chat box at the end of the session so that people can rejoin the main session, because you'll have to leave this session in order to rejoin the main session. So I would like now to introduce our first speaker, Dr. Lisa Hinton. Lisa will have a video that she has pre-recorded showing, and we'll watch that and then we'll be able to ask some questions to Lisa. So a word of introduction about Lisa, that Lisa is a senior social scientist at this institute, which is the Health Improvement Studies Institute. And it's based in the Department of Public Health and Primary Care, and she leads a programme of work using applied social science research to understand patient and staff experiences and improve care. She was previously Director of Applied Research for the Health Experiences Research Group in the Nuffield Department of Primary Care in Oxford, and she worked there from 2010 to 2019. Her research now specialises in pregnancy and pregnancy complications, childbirth, maternal morbidity, neonatal and adult intensive care. She uses innovative, qualitative health research to develop and evaluate complex interventions and to inform health policy and service improvements in both the UK and in low and middle income countries. Today she'll focus on her work with colleagues at MUII in Kenya, and she's been working with them for over 3 years, and her presentation is on exploring the potential for using mothers' experiences of preterm birth to improve care in Kenya using video narratives and digital stories. So I hope we'll be able to view her presentation now.
Good afternoon. My name is Lisa Hinton, and in this session I'm going to be talking about using patient experiences to improve care, with focus in particular on maternal and neonatal health in Kenya. But I'm going to start us off with a quote from two doctors published in JAMA in 2011. They argued that narrative is often maligned as an anecdote, and thus scrubbed from the toolbox of guideline developers, epidemiologists and regulatory scientists. These experts, they suggested, should consider narrative to develop and translate evidence-based policies. There's a long-standing tension between qualitative and quantitative research that I'm sure you're familiar with. But what I'd like to argue in this session is that qualitative research can give us rich insights into what an experience is currently like and that to help us develop a platform from which to measure if improvement activities make a difference. Qualitative research can tell us not just what is wrong, but also develop a rich picture of what good looks like and what could be better. These insights can help us challenge assumptions and help us realise that some things matter less to patients than we think, and they can be a powerful motivator for action and remind us what we're trying to achieve. Why do experiences matter? Well, they're now globally accepted as one of the 3 pillars of quality of care, alongside safety and effectiveness. There's a well-established link between patient experience and self-rated and objectively measured health outcomes, and growing evidence that suggests patient-centred organisations have better clinical safety, improved staff experience and morale, lower operating costs, shorter lengths of stay, and reduced malpractice claims. And they can impact at the health systems level as well. The Lancet Global Health Commission, that published almost exactly 2 years ago in November 2018, set out a research agenda for high quality health systems going forward that included patient experience and patient reported outcome measures at its heart. There are many different approaches to researching patient experiences, ranging from the in-depth observational work of ethnography through to interviews, focus groups, to patient experience surveys, patient reported outcome measures, and systematic reviews. Each of these give us different insights into patients' experiences of their health and illness and care. One approach that I'd like to introduce you to this afternoon is called Health Talk, which has been run out of the Health Experiences Research Group in the Department of Primary Care in Oxford for the last 20 years. The Health Talk approach includes conducting open-ended narrative interviews, either audio or video recorded, with individuals about their experiences of health and illness. Each collection aims for a maximum variation sample, which normally includes around 40 to 50 interviews undertaken all around the country. Analyses are published in peer-reviewed clinical and social science journals, also published on the Health Talk website. This website now includes over 110 different health conditions, which include clips from interviews with people about their experiences of illness. The video-based resource is aimed as a resource for public and patients to learn about the health and care experiences of their peers, and can also be used by clinicians in training or medical undergraduates to give them insights into patient perspectives. There is now an archive of rigorous qualitative research that's available for secondary analysis. And these studies have been used for multiple service improvement and co-design projects over the last 2 decades all around the country. There's also an international collaboration called DIPEX International, which now includes over 14 countries around the globe, which supports cross-country comparisons of patient experiences and priorities. One of the exciting projects that's been kicking off this year is a cross-national study of people's experiences of COVID, with in-depth interviews being undertaken in all of the countries taking part in DIPEX International, with patients' experiences of COVID in their own countries. But I want to tell you a little bit about work that we have been undertaking in Kenya in the last few years that seeks to test out the potential for patient experiences research to improve care in lower middle income countries. The majority of work that has been done in developing patient experiences research over the last 2 decades and testing its potential for improving care has been done in high-income countries, and there's relatively little evidence for how patient experiences research can be used to improve care in lower middle-income countries. And that's what I've been doing with colleagues in Kenya over the last few years, collaborating with Mike English and his colleagues, who have been developing a program of work to improve neonatal outcomes and care. The research I want to introduce you to this afternoon has formed part of Dorothy Olawach's doctoral research, and she has undertaken in-depth ethnographic work in 2 newborn units in Nairobi to try and understand more about mothers' experiences of having a baby prematurely and cared for in a neonatal unit. To give you a bit of background, globally 3 million newborn deaths occur annually, largely from preventable causes. Many countries in sub-Saharan Africa fell short of their Millennium Development Goals of reducing under 5 mortality by 2/3 by 2015. And neonatal deaths account for 45% of all under 5 deaths in Kenya. It's a significant problem. One approach that seeks to improve these outcomes has been something called family-centred care. That's a strategy for improving hospital care in neonatal units in hospitals. Family-centred care emphasises the relationship and the partnership between the family and healthcare providers. But to date, there are few studies focusing on parents' experiences of neonatal care in low middle-income countries. And the involvement of mothers caring for their newborns, their hospitalised sick newborns, is relatively poorly understood. So Dorothy's work has been to focus on 2 hospitals in Nairobi, 2 starkly different hospitals. One a public hospital, very overcrowded, under-resourced hospital, and the other a mission hospital. She undertook non-participant observation for over 300 hours in each setting, and in-depth interviews with mothers caring for their babies in the newborn units, 20 in each site. And she tried to follow up with many of these mothers, doing in-depth interviews after they'd left home and taken their baby home with them. These are the 2 hospitals. The public hospital is here, seen here on the left, and the mission hospital here on the right. And the context is that these 2 hospitals are strikingly different in their staffing levels, their infrastructure, the available space and general physical geography and social environment. And these differences, these physical differences, suggested considerable inequities between the mothers in the 2 hospitals in their potential ability to access appropriate and timely care. And what Dorothy's work seek to understand is whether these differences impacted on the roles and the experiences that mothers have had of newborn care in the neonatal units in these hospitals. And her work, recently completed, has found stark differences between the mothers' experiences in the 2 hospitals. And just to give you a quick flavour, this illustration here illustrates mothers' experiences in the first 24 hours after their babies have been born and they're being cared for on the neonatal unit. On the left-hand side, you can see an illustration of what we call Kijani, the public hospital. And in this setting, mothers are involved in caring for their babies. Immediately they're transferred to the neonatal unit. They're involved in expressing milk, NG tube feeding, and changing their babies' nappies and general care. And there is very little supervision from the clinical staff in the care that the mothers are given. By contrast, if you look on the right-hand side, the mission hospital that we've called Tausi sees that the mothers have very little involvement in looking after their newborns in the neonatal unit, and that the care is mostly done by nurses who bottle feed the baby and do all of the nappy changing, etc. And the mothers have very little involvement. Dorothy has summarised this by showing that throughout the stay of the babies on the neonatal units, in study A, the public hospital on the left here, mothers are involved from day 1. They tend to stay in hospital. They're involved in feeding, monitoring and cleaning with very little supervision from the nurses. And they learn how to cope and care from other mothers on the unit. By contrast, in study B, the mission hospital, mothers are not involved in looking after their baby until the baby's transferred out of the neonatal unit. Few of the mothers stay in hospital. They're not really involved in feeding and cleaning, and they get very little involvement and community support from other mothers. So Dorothy's study has concluded that the involvement and the role of mothers varied greatly between the 2 hospitals that she studied. In the public hospital, the mothers were providing a huge amount of care for their sick babies right from the get-go, with very little guidance and supervision from the nurses. And this impacted on how the mothers in the 2 different settings felt about their experiences. And these experiences and understanding these experiences are vitally important in terms of responding to their concerns and understanding how we can start to develop enhanced family-centred care. Dorothy's doctoral work is now completed, and this study this slide rather gives an acknowledgement to the supervisors and the various institutions that were involved in that research. But Dorothy and I are taking this work forward in a new grant that we started a couple of months ago, funded by the MRC and the UKRI Health Systems Research Initiative, where we're building on the narratives that she's already collected, and we'll be collecting new interviews with mothers of newborns in neonatal units in a new sample of units, both in Nairobi but also outside of Nairobi, to get a bit of variation there. And we're going to be using these insights to develop new training materials for neonatal nursing staff, primarily neonatal nurses and healthcare assistants. We'll be delivering this training and then evaluating its impact to try and understand more about the potential for using patient experiences in training and healthcare improvement. Thank you very much for listening, and looking forward to the discussion and answering any questions that you might have. Thank you.
Thank you very much, Lisa. That was really interesting. I'm opening it up to, if anybody has got any questions, either please put your question in the chat or show that you've got a question using the raised hand. In the meantime, while others think of their questions, I realise that some of the information is probably can't be shared because it's unpublished as yet. But I was wondering if broadly you could tell us a little bit about the different feelings of the mothers in the two different types of settings.
Yes, can you hear me clearly?
Yes,
Hi,
very
super. I think the really strong finding to come out of the comparison of the two sites is actually the distinction between the social support that the mothers provide for each other in the public hospital versus the social support that is less available in the mission hospital, where mothers are on the surface have more social capital, that they tend to come from better off communities, they're able to travel home and live at home with their families while their babies are on the neonatal unit. But what they lose with that is the sense of community and shared learning. So while the conditions in the public hospital are not nearly as good, and the provisions for the caring of the babies is not as good, but the mothers are able to give each other support, and there's a real sort of sense of social support from being all in it together and staying in the hospital together.
And was there also a greater confidence that the mothers felt in then returning home?
Yeah, absolutely. So the mothers are they're learning from each other. And so, often new mothers with very premature babies who might not, or even if they're already a mother, they might not have had a premature baby before. They are learning from the experiences of the mothers who've been on the neonatal unit for a bit longer. So there's a real sense of confidence that rapidly comes quickly through. So language barrier, I can see a question there. That's a really good question. So one of the kind of the founding pillars of trying to seek maximum variation sampling in interviews, studies that we've done in primarily high income countries is it's much easier to travel around the countries and not have to deal with language barriers. Whereas Kenya has got a hugely diverse population in terms of languages and different tribes, and it's also it's a much larger country and much harder to travel around. So that is one of the challenges of doing that kind of work, that kind of rich patient experiences work in a country like that. Dorothy, who did most of the interviews, is a Swahili speaker, so she was able to do interviews in Swahili. And we've done some pilot work doing some video interviews, and we also did some interviews in Swahili for that. But that is undeniably a challenge for doing that kind of work in Kenya. Tom is saying how to integrate narrative analysis with non-dominant forms. How can I answer that in a minute and a half? I think that's that's one of the things that we want to think about trying to tackle in this project is build on, the project going forward is to build on the rich evidence that we can get and the insights that we can get from patient experience data, but try and use that in a way that we can evaluate in terms of trying to improve staff training, and in some way try and integrate some of our findings there. But I think it's a bigger question than in 3 minutes to kind of think about integrating with epidemiology and statistics. But I think we have to get these different paradigms to be talking to each other a lot more.
And then Arthur asks a more constrained question.
How involved was the county government? But I think very involved. I mean, one of the benefits of, Mike English has been living in Kenya for the last 20 years and has been absolutely integral to the Kemri Wellcome Trust research program there, which is based both in Nairobi, but also out, in other settings as well. And they have had long-standing engagements with both the Ministry of Health, but also the county since devolution as well. So engaging with both county level, ministry level, and also strong engagement with the professional organisations, the associations for nurses, neonatal doctors and things like that is absolutely at the core of what they do there. So Mariam's saying, I understand this is about patient experiences. Was there a difference in outcomes? That was, that wasn't the part of that's not part of anything that we can evaluate in this study. But it would be great in a bigger study if we could actually demonstrate that baby outcomes were improved by understanding mothers' experiences more. That's a good question.
I couldn't quite formulate the question in my head. I think what I'm trying to ask is, obviously, I know you weren't looking into sort of outcomes, but was there any way where you were correcting for outcomes and kind of seeing how that affected the experiences more? Because I presume if there was going to be a difference in outcomes, that would affect the experience perhaps more than whether the mums were able to interact with the babies on NICU.
Do you mean if the babies are having poor outcomes themselves, or? Yeah. I mean, I think, obviously every mother has a slightly different journey through a neonatal unit, and her babies will thrive or not. What I should have done is provided a link. I'll see if I can find it during the next presentation, and I'll put it in the chat. We did a pilot bit of pilot work about a year and a half ago that we made into a video, which is on YouTube, which I'll link for you, where we were trying to test the premise of doing video interviews with mothers and trying to develop digital stories, which is what we're going to be doing in this next grant. And it's clear from the narratives of just doing some of those interviews that mothers are acutely aware of obviously both their own baby's trajectory, but also each other's baby's trajectory. And they sadly get exposed to a lot of death and sickness during their times there. So I think that mothers' experiences will be different depending on what they're exposed to, but absolutely, I think they're impacted by both whether their own baby is thriving. There's quite a lot in the film. You'll see there's quite a lot of kind of healthy competition between babies gaining weight and things like that. But it's part of the humour and the community that they develop to try and support each other.
That's great. That was a really interesting presentation, and we really look forward to hearing more about it when more is on this. So
definitely come back and tell you more as we develop the research. I'd love to. Thanks, everybody.
Thank you very much. And I'll now invite Arthur to share his screen while I introduce him so that he can then start once he's introduced. So Dr. Arthur Kwizera is a lecturer in anaesthesia and intensive care at Makerere University College of Health Sciences, and also a staff intensivist at the Mulago National Referral Hospital. Both are based in Kampala in Uganda. And he's also undertaking a PhD as part of the Thrive programme. His research focuses on acute respiratory failure and acute respiratory distress syndrome in Ugandan hospitals, and is exploring the prevalence, outcomes and effect of respiratory interventions to improve outcomes. Arthur has recently been very busy tackling COVID-19 in Uganda as a clinician, but also on the Ministerial Scientific Advisory Committee in Uganda. And he's also a member of the WHO's COVID-19 expert panel. So I'm delighted that Arthur is able to make the time to tell us about the work he's been doing around acute care in Africa and improving outcomes through collaborative research. So I'll hand over to you, Arthur.
Thank you, Corinna. Can you hear me?
I can hear you perfectly.
Thank you. Thank you very much, and for that very kind introduction. So when Tom asked me to say something about this, it was a very, let me see, sharing my screen. Yeah, interesting idea, because talk about this topic in 10 minutes is going to be quite a work, quite some effort. But yeah, let's talk about Africa. So we are a very big continent, and a few facts: multiracial. We are almost 1.5 billion people with a fairly significant growth rate. I think we outstrip every other continent. Right now, we shall be, by 2050, we shall be slightly more than a quarter of the world population. And most of this growth will be driven by Sub-Saharan Africa. And we've seen over time that due to various improvements in different outcomes, life expectancy is now at about 63 years as of this year. A brief history of healthcare development. Everything up to 1987, as you all know, we'd had various versions of strife, and in the Bamako initiative was meant to bring the attention of African health governments to the issues of health in Sub-Saharan Africa, and to increase access through community involvement in revolving drug funds, and essentially building upon the primary healthcare component. And we did have a fairly good run across Sub-Saharan Africa until HIV came. And it absolutely decimated our healthcare systems. It just, it changed the landscape of healthcare, mostly negatively. We had a lot of people passed away, and we account for 2/3 of the world's infected. And from a healthcare capacity perspective, there was a huge brain drain aspect. We had a lot of the specialists who had returned to Africa around that time had issues with got dragged into research in health, in HIV care, and as a result of that, ended up with a situation in which we then and then had very few clinicians involved in healthcare. Then, oh, sorry, something is up. I'm sorry, let me just fix this. Can anyone see my screen?
Not at the moment. Our technical team could share the slides from this end if you'd prefer.
Let me. I think I hit a wrong button.
That's great. We're back to your slides.
Okay. Let me. Okay. And so basically what happened is that the gains that had been made in the early 80s, in the late 80s after the Bamako initiative got completely derailed. So some of our best specialists left the main clinical scenario, and everybody, so that we had what we call internal brain drain, and a lot of resources went to combating the HIV pandemic and left a very thin support for our healthcare infrastructure. With regards to critical care beds, since this topic is mostly on acute care, as of the last count, we had less than 300 ICU beds in 12 sub-Saharan African countries, which accounted for about 0.7 ICU beds, or 1 bed per million people, compared to, say, countries like France that had, have significantly, and Italy, which had a significantly larger number of ICU beds. So which meant that this is, in the background, there's just an ICU in Kampala, which has the basic intensive care service provisions. But essentially it meant that almost 99.9% of any acute care, including care that would happen in the ICU, is happening outside of the ICU. When it comes to research regarding around in general, if you look at the map, these are just clinical trials. You can see that Africa and other low-income countries are very seriously behind, and yet one would argue this is where maybe 85% of interventions need to be tried and tested for the low middle income countries to come to par with standards of care that are in high income countries. So what can we do? My focus of this talk is essentially, this is a research focus, so I will stick to just saying that we need to have equitable, contextual, and inclusive research. The barriers to research are many. I do not know if I can exhaust them in this time, but they are largely within these domains. The first thing, even from a personal perspective, was the attitude. In our time, when I was a medical student, almost all research was in HIV. And so everybody assumed that HIV was more or less the only disease that needed research because it was the only disease that was killing everybody. So research in other areas like maternal child health, we've just had the NICU, the Kenyan work with regards to NICU care being discussed. All those took the backseat with regards to priority. The other thing is that there was also some sort of elitist attitude. So if you didn't do HIV research, you were not considered a researcher, and as work has been published in that regard. We have the issue of competing demands. In our department, we are maybe about 12 faculty, and yet it's a university department. So we have got to do research, we've got to handle clinical work that is required by the hospital. And at the same time, there is what we jokingly call black tax. Every young African grows up in an extended family, and very few go through and become what you would call educated. And in Africa, being educated means that you should have the means to take care of those that do not break the ceiling, and as a result, there's a lot of pressure on any educated African to take care of their extended family. So whereas in the West, you have your wife and 2 children, because if fertility rate is low and there's a much better family planning, I would typically have myself, my 8 children from 2 wives or not, and then my uncle's children and so on, and have about 20 to 30 people that I'm looking after. So all my life, for as long as I'm able to live, my focus is on taking care of these and raising other children that are not necessarily mine. We call that a black tax. And this is a very, very serious burden on any educated African, and even worse on healthcare providers. The research environment is generally not conducive. You will see that even within our education framework, the curricula do not really inspire people to ask questions. And so it's more about, the curriculum is more about regurgitation and of knowledge and being able to reproduce information, and of course become, very good mathematicians and so on. So at the top of the pyramid, it's very narrow. Funding, and I think that is not just a problem in low-income countries. I think even in high-income countries, that can be a challenge. I don't need to go very much into that. We also have regulatory system obstacles. There are delays in obtaining regulatory approval. Even when you get approvals at the highest national body, you still have to go to the lowest, it's politicized. So you have got the government, the district hospitals, the ministries, and so on and so forth. Then of course there are operational barriers within the sites, because health workers are not research trained. You've got to set things up from the beginning. The environment is not a research environment, it's an operational service delivery environment. So to bring a research focus into that environment, that's a very alien thing. So you'll go to one hospital up country and there's an office for UCSF, an office for the Cleveland Clinic, there's an office for Oxford, there's an office for, so it becomes, some sort of village. And if you look at the base camp and Mount Everest, there are all these little huts of people trying to get to the summit. And that's sort of, I was trying to look for an analogy. It's what you will see in a typical hospital. That to mention but a few. And of course the issue with the attitude is the fact that the idea that outcomes research will not impact, because there's a very big problem with translation. There is the so what aspect. And so these are some of the barriers to research. I've not exhausted them, obviously. So just briefly about how we tried as a department to turn around this. I will try to use a personal context. I was an Association of Anesthetists of Great Britain and Ireland overseas fellow. I was the first overseas fellow trainee. And so in about 2008, Dr. Isabel Walker I was working in the OR and we were doing cleft palate cases. And so she happened to have the case, I was doing my case, she was doing her case, and then her child gets an arrhythmia, an tachyarrhythmia, which we believe was induced by the relationship between epinephrine and halothane anesthesia. And she tried various ways that she knew from the Greater Ormond Street Hospital, where she was a consultant anesthetist, and that didn't work out. So I said, well, we can use magnesium. And she's like, I've never used that before. So I ran up to the obstetrics theater, because there was a MUII study that was looking at magnesium and preeclampsia. We administered it, reversed the arrhythmia, and she said, we could write this up. The component, the concept of me writing something up was very alien. But this case report encouraged me quite significantly. And I'll tell you, she probably wrote 90% of it. But the fact that she mentored me, and it really, really, really spurred me on, it gave me the drive to say, you know what, we can actually start to write our own story. And so one of the things within the department was now for us to start to understand the importance of research in improving outcomes, mentorships. We had quite a few visiting anesthetists from other countries, predominantly the UK, the AIGBI, as Canada and the United States. And then of course the department we started to actively recruit like-minded and very smart, forward-thinking colleagues. And we realized that the best way to get through this was to work with our strengths. We had very huge obstetrics caseloads where we could actually conduct a lot of the studies quickly and easily. And then of course, creativity with the resources. So one of the things that we did was, okay, and I'll share later, is we would use what was within the hospital resources to answer the research question. So we had a clinical trial, for example, propofol versus thiopentol, which is what is the better anesthetic for a mother who is undergoing C-section under general anesthesia. So I remember one of our colleagues, Dr. Janat, did that for her dissertation, and it got published in a very good anesthesia journal. And we probably did not spend £100 for the whole clinical trial, which was a very well-powered study. And then of course, advocacy. I asked about how the government was involved. So starting to have discussions with the government about improving care, but then showing them the data. So we had to generate the data to show them. It's all bullet pointed, but it was very haphazard, full of disappointments. But this is just how we got there. So the first study after Isabel's very big kick.
Please. Sorry, we're running short on time.
Yeah, sorry. So we came up with this. This was the first study. It had many rejections, but it was the first to describe acute care capacity in low- and middle-income countries, and it generated quite a lot of interest. After that, we've gone on to publish about 8 clinical trials and more than 20 observational studies. And I mean, it's still a struggle. So to anybody wanting to come to do research in low-income countries, there's this will, and in no particular order. One, relationships matter. Africans are about relationships. You need to have local champions. You need to be patient. You need to be open-minded about many things, because some things that work in your system will not work in ours. Failure is almost certain at a certain point, but you're guaranteed that if you stick in, you'll make a positive difference. So thank you very much, and let's keep working towards helping low- and middle-income countries. Thank you.
Thank you, Arthur, and thanks for that positive end of sticking in there makes that difference. And I'm sure you're making a big difference in Uganda. Are there any questions to Arthur? Right, Tom has got a question. Would you like to just put it to Arthur?
I think I've read it. With all the new global health research funding coming from the UK via UK Aid, do you think this should be going directly to low middle income or be hosted by UK PIs? Yes, I think, I'll be very honest. I think that it can be a 50-50, and it also depends. I think the collaborations, the UK PIs and the low middle income country PIs should have the flexibility to make a decision on that, because there are going to be situations where some low middle income country PI departments do not have the, sort of the grant management systems that are necessary to handle the funding, or might not have the systems. And there are others that will be, that can have very strong systems in place for that. But again, I talked about equitable partnerships. So yes, I think, but as long as the funding, almost all the funding will be spent in the low middle income country, to answer that particular question, I think that was what is important. Do we have rapid systems for it? Yes, we do have expedited review processes, and again, we also have to be creative. You have to be very clever about how you go through the system, because there are some questions, or that there are some proposals that will undergo a lot more scrutiny than others. But yes, there is a rapid system. Our students, are there any other ways we can get involved in research? Yes, yes. I think I was about to say, one of the things, you can just send an email and develop relationships. That's the thing. We Africans generally, like, as you can see, we like to talk, we like to hang out, we like to look you in the eye and tell you what we feel. So develop relationships with people, but send an email, talk about what you'd like to be involved in, and then if we do, then we can find somebody on the continent who can get you up there. And if you start at medical studentship level, that's very good.
Thank you, Arthur. That's great. People will put further questions to you by email, and we'll hand on to give Rose enough time to give her presentation to finish off this interesting session. But thank you for a really interesting presentation. So Rose, if you'd like to start screen sharing, and then while I introduce you, and then we'll listen to your presentation. So Rose Eichenberger is a Global Health Research Manager in the Cambridge Research Office. She's been mapping the global health activities on the campus, and she works together with colleagues in the various strategic research initiatives and interdisciplinary research centres. She was previously the Programme Manager for the Tigris Programme, which works on sustainable food supplies in India, and has worked as a Programme Manager at the MRC Epidemiology Unit, as well as in a wide variety of health research and clinical trial roles. Rose is keen to find out about potential opportunities for collaboration and happy to help forge new partnerships. So as with Arthur, please get in touch with Rose after today's session if you have any comments, suggestions, ideas for these new partnerships. And today Rose is going to provide us with an overview of global health research at the University of Cambridge. Over to you, Rose.
Thank you, Corinna, for the introduction. Can you hear me all right?
Yes.
And you can also see my slides.
Yes.
Right, I'll get started then. So as Corinna said, I will give a very brief overview of the global health research activities in the University of Cambridge. So my presentation will be slightly different to the other two, but I hope still quite interesting to hear. So let me start with giving you a little bit of a background on the global health funding landscape. So as you may know, the UK government pledged a 0.7% of national income as an aid budget. And you may have heard in the news that this is likely to be reduced, but it's still a significant amount. The funding allocated for aid research is about 1.86 billion. And this funding can be used for research projects with partners in low and middle income countries that are ODA compliant. So they are looking at the country's needs and other matters. So the funding is administered through various different agencies, most notably the UKRI Global Challenges Research Fund, but also NIHR Global Health, the Newton Fund, and some other sources. And the health research funding budget is about £536 million. There are other funders that have a big global health research budget, including the Wellcome Trust, but also the WHO and Gates Foundation. So you probably have seen the numerous funding calls. As Tom also mentioned, there's a growing number of calls around. And as you might understand, more and more University of Cambridge researchers are either applying to these funds or asked to collaborate with partners. So just from looking at our grants database, so this doesn't include internal funding like Cambridge Africa. This doesn't include departmental funds or some charitable donations. So just the external research grants that we held in the research office, we have about 92 active grants for global health research projects with partners in low and middle income countries. And there are about 64 different principal investigators working across about 24 different departments. But the majority of the projects are run from the departments of clinical medicine or veterinary medicine, but also biochemistry, genetics, chemical engineering, and many others not listed. So projects have grown rather organically, and they're very much PI-led, as is in the University of Cambridge. So there are numerous different projects in various different topics, and I roughly divided them in 29 themes. The majority of projects are in infectious diseases research. And this ranges from lab research projects looking at host pathogen interactions or genetics aspects, all the way through to full-scale vaccine studies with in-country partners. We also have quite a few oncology projects and a few large programs looking at other non-communicable diseases, including diabetes type 2, cardiovascular diseases, and some determinants of health, including active transport. There's a growing number of projects looking at mental health, which is also a priority of some funders. For these projects, we work with partners in around 59 countries, and Uganda is in the top 10. We have at least 20 projects in Uganda with partners in Uganda. Some of them are led by the same teams, and we have between 10 and 20 each, 10 and 20 projects in the other countries listed here: India, South Africa, Bangladesh. And you'll probably see this reflected on the mural. I think Uganda and Bangladesh and India, they're kind of covered with post-its. And it's very interesting to see all those projects appearing. We also work in about 24 countries where we just have one active project at the moment, and there are about 15 countries where we have 2 or 3 projects. And as you can understand, there are many countries where we currently don't have partnerships. Some other global health research related activities include some of the exchanges programs. So the university runs various exchanges for lecturers, students, and postdocs. They're all kind of managed by different offices, including Cambridge Africa, but also human resources. They used to have a global health internship scheme. I think it's currently paused. And then within my office, the research office, we developed a administrative development program, and I think they've done 2 courses, and they're currently developing the 3rd to be going online. And at the moment, it's aimed at administrators from partners in sub-Saharan African countries, but we hope to expand. So if you want to hear more about this, please get in touch. As you will have seen on the mural, and maybe from the various other talks, there's a range of network centers, hubs, groups, programs that are all involved in global health research in one way or another. So namely Cambridge Africa, and Corinna can tell you all about what they do. We also have a network named Cambridge Infectious Diseases. We've got Cambridge Global Challenges, who focus on all the sustainable development goals, and they support many different projects across many low middle income countries. And then we have the recently launched Cambridge Public Health Interdisciplinary Research Network, who presented at day one of the conference, and they have a new global health theme. And then Wolfson College recently launched their Global Health Research Hub. And I'm sure there are many more networks, and some of them are already listed on the mural. So what else did the university do to support this growing interest in global health research? Last year, they recruited 2 new posts in global health research. One of them is the Research Governance Advisor in International Studies. Jane Gaffa is based in the Clinical School Governance team, and she can advise you on all things relating to ethics, local regulatory approvals, and all other requirements for global health research internationally, but including low and middle income countries. And the Global Health Research Manager, and I'm based in the Cambridge Research Office, but I also have strong links with the Strategic Partnerships Office. And my role is to help forge new partnerships, signpost people, make sure that applications and projects follow university guidelines and policies, and help ensure you follow the right reporting guidelines. And I'm also here to give you generic advice. So yeah, feel free to get in touch if you want to talk with me about your projects. Core support from other teams within the university. Also in the research office, we have a dedicated GCRF coordinator, my colleague Mercedes. She mainly manages, she not only manages the internal GCRF QR funding, which we have used to fund various projects focusing on sustainable development goals in low and middle income countries. Mercedes is also available to give advice on ODA compliance and other relating matters. And we have a dedicated due diligence team who perform checks on partners that are required by some funders. When we work with new partners, there's a set of checks they follow. When you're developing a research proposal, we have dedicated research development teams who can help you on your proposal in general, including ODA compliant research. And we also have a dedicated new contracts manager who works on contracts with partners in low and middle income countries. Support from other university offices includes the strategic partnerships coordinators who help develop new partnerships with institutions in countries across different regions in the world, including Southeast Asia and African countries. HR recruited a global mobility coordinator who can help support and advise with all matters relating to working abroad for longer periods of time. And then we have an insurance team who can help advise when insurance is required for some international projects. So in summary, interest in global health research is growing. There's a lot more opportunities, and hopefully after this conference, there's more and more partnerships and ideas for collaborations. There are quite a few local networks to help you build links. And please have a look at the mural as well, and hopefully find new people to work with. There's university support available across different offices. And yeah, I'm looking forward to collaborating for impact, and I wonder what will the future bring. So there's some further reading. We have dedicated global health research website on the research office website. There's also a website about international research on the Clinical School Research Governance website, and I'm happy to share these links. And I think that's the end of my presentation. Giving you a brief overview of everything that's happening across the university, hopefully, and I look forward to hearing some of your questions.
Thank you very much, Rose. In fact, it was really enlightening for me to hear about a lot of the structures. I've been working in this area for 4 years, and I'm talking about, so I'm sure it'll be very enlightening for others as well. Have you noticed any major gaps that you are particularly keen to look at trying to fill around research, or research focuses that you feel that really there should be more effort for Cambridge to reach out?
Oh, that's a very good question, Corinna. I think one of my problems was the other way around. There's so many different things, and how do we find a priority? But one of the gaps I think people are talking a bit more about child mortality, and I was also thinking about, following some of the presentations as well, maternal health. Although I know there have been projects in the past, I haven't seen that many recently. And also, we seem to be focusing on some countries mainly, and some other mainly low-income countries. We don't seem to have a lot of activity. So I think it would be really good if we could focus there. But as I said, the research in Cambridge is very much PI-led. So we don't really have that top-down kind of approach.
There's a request to share your slides, obviously for other people as well. It's been very enlightening about structures that people are...
Absolutely, yes.
And also initiatives.
Some of it is also on the mural, so please do have a look there.
And Tom has got a question.
I'm just reading it. So I don't know whether you can all see the comments. Tom is wondering about what the university feels about leadership in global health research. Much of the rhetoric is about being a research leader, but this might be argued to exacerbate a lot of the existing power imbalances. That is a very good point. I find that really difficult to answer. I think the funding landscape, the changing funding landscape helps, where some of the funders allocate the funding directly to partners in low middle income countries. But I agree with you, Tom, and I think some of the others commented as well, that we have to change our attitude and very much work with partners. And I think, well, a lot of people realize that there's a lot of mutual learning. It's just a change of the narrative, I think. It's a very good point.
Well, we seem to be ending more or less on time. Actually, Arthur's got his hand up, so if you ask your question, we'll still be able to end on time.
Okay, thank you so much, Rose, for that. So I have, about 3-4 years ago, we put together a WhatsApp group of African doctors engaged in intensive care, acute care practice. And the thing that I noticed about this group, I put this group together just for collegiality and, throw until something sticks sort of. One of the things that we noticed, and a recurring theme from all of them is talking about how the Northern partners do not understand the African culture with regards to research management. Is that something that you have, is that feedback that you have gotten? Because I do know that what happens in Kenya might be different to the situation in Uganda. And I think Tom alluded to the issue of, maybe when I was talking about the hierarchy of research leadership and that sort of thing. Yeah. I don't know if that's something that has come back to you, and if that's something you're thinking about being more flexible about.
That's also a very good point. I've not really worked with African partners myself very much, but I've heard feedback from others where they said the expectation, so the way the UK funders expect us to manage the grants and to do the reporting, it's very much a UK focus, and it doesn't always cater for the way things are managed with African partners. So what we've done, I know this is probably not, I don't know, I can't say this is not the right response, that's not a good way to say it, but what we've done from the research office point is my colleague Debbie West-Lewis has developed a training program aimed at administrators, which teaches the financial and administrative stuff about how the UK funding landscape works and what funders expect and how we are expected to manage these fundings and this is very early stage. So Debbie has run a few courses in person with small groups of people, and she acquired some funding to run these courses. And at the moment, she's developing some of the content for online presentation, but we need more funding before we can roll it out more widely. But feel free to contact me, Arthur, and we can maybe discuss a little bit offline, because I think there's definitely a request from people to get these training courses. But I think taking a step back, I think we should perhaps think a bit more about how partners in sub-Saharan Africa and other low middle income countries, how they run their grants, and whether we can be a bit more flexible. But this comes very much from the funders at the moment. But this is definitely a discussion that's very, very much worth having. thanks for your question. That's a very good point.
And there's one final question from Christian about formal mechanisms for mentorship working global health through the University of Cambridge. Rose, I'll put it to you first, and then I can mention a little bit about Thrive and MUII, which is very much...
that would be good. Yes, I've got two screens, so I have to move. So Arthur spoke powerfully about the power of mentorship. Are there formal mechanisms or illustrative examples of mentorship working in global health through the University of Cambridge? That is a very good point. And I've only been in my post, well, for nearly a year, and with the pandemic happening, I haven't been able to make as many connections as I wanted. But I need to find out a bit more about this. I'm not personally aware of any mentorships, but I'm sure this is happening. And I know quite a few people are doing capacity strengthening activities. So, so Corinna, you mentioned that you may be able to expand a bit more.
Yes, so both the Thrive and MUII programs are linked to Cambridge primarily because of mentorship. So people who are undertaking PhDs and postdocs in Africa on African research priorities, funded through African universities by these programs. So the funding is in Africa. What I do as a Cambridge coordinator is match people with a Cambridge University mentor. So they have their own supervisor in their own university, but also a Cambridge mentor. And the schemes I work with have funding so that the mentee can come to Cambridge and spend some time in Cambridge, learning whatever research skills that are best provided in Cambridge compared within their home institution. And there's also funding for the mentor to go and visit the African researcher, because as has been pointed out very often, there's a lack of understanding of the research environment and the situation in the mentee's environment. And so actually having those reciprocal visits are very important. But this really only happens through having a funded program where there is somebody to actually make these linkages. I think otherwise it's quite difficult for these things to actually happen without actually more concerted action to ensure and maintain those linkages. So I can see, though, that it's now 3 o'clock, and I would hate to stand between any break between people and starting again at 3:15. So just before everybody heads off for their tea break, thank you so much for those wonderful presentations from our three presenters, Lisa, Rose and Arthur. It was really interesting and very diverse, and please get in touch with the presenters either through the conference if you have further questions that you want to take forward. And please leave this session at this point and then rejoin through the link that I think was posted, or otherwise through the portal that we were given, and that should be on your conference information. So thank you very much and enjoy your tea.
Thank you.